pattern for you and to think of a disease according to the pattern. In clinical practice, there are two different types of clinicians, the systematic excluders and pattern spotters. The pattern spotters are fast, but sometimes looks can be deceiving, such as this strategically placed infarct in the hand knob area, giving rise to a Registrar, mimicking a peripheral nerve disease. So therefore, it is important in pattern recognition to go through proper history, where also you need to use pattern recognition, examination, and also observations along the progression of the disease. Today, we are going to take a journey in the terrains of lower motor neuron diseases. So the first journey is a journey along the anatomical distribution of lower motor nerve, and then we are going to take a journey backwards. So we will discuss patient presentations. And then thirdly, I will introduce a few signs that you can elicit on examination. And finally, we will summarize. So let's start our journey. So starting with the anterior horn cell. Now, anterior horn cell is located in the anterior gray horn. So this can get damaged with neurodegenerative diseases, which you all know, motor neuron disease, and also with some rare neurodegenerative diseases and infections, particularly enteroviruses and flaviviruses. Moving on to the root. Now, when it comes to root and plexus diseases, the important differentiation here is to understand preganglionic diseases versus postganglionic diseases. So when it comes to this differentiation, now preganglionic patients will have a lot of pain and will have a lot of sensory symptoms, whereas postganglionic, the sensory symptoms may be localized only to the particular dermatome. And in nerve conduction studies, the classic pattern of intact sensory amplitudes will occur in the preganglionic because it is proximal to the dorsal root ganglion. Because of that, your wire, the lower motor nerve, the sensory nerve, not the motor, the sensory nerve is intact. Because of that, the amplitudes are preserved. So in this case, you will get the classic pattern of reduced motor amplitudes with spared sensory amplitudes. Then again, when it comes to your cervical roots, now your brachial plexus, so it also has the roots. So in proximal brachial plexus injuries, you have two different nerves, the dorsal scapular nerve and the long thoracic nerve, which when affected will give rise to winging of the scapula and rhomboid weakness. So these are telltale signs that these lesions are preganglionic. So now this is the gist of today's presentation, the peripheral nerve disorders. So along the way, now when we come across peripheral nerve disorders, we can classify them according to different patterns. So according to the temporal dispersion, we can classify according to acute and chronic diseases, and in the middle subacute. Then according to the components that are affected, we can categorize them into sensory motor, and motor diseases. Then again, the pattern of involvement, whether it is diffuse versus patchy versus single nerve involvement, and also whether or not the cranial nerves are involved, we can classify the peripheral nerve diseases. The last classification is with pathogenesis, whether the axon is damaged or whether the myelin sheath is damaged. So there are axonopathies and myelinopathies. And there's a somewhat new entity called nodopathies and paranodopathies, which are also coming under myelin sheath disorders, where there are antibodies against the node of Ranvier structures. So, lastly, neuromuscular junction disorders. Well, that is a separate now. I can talk for a day, but therefore it's not included here in the interest of time. So neuromuscular junction disorders are also important. So here, the classic thing is myasthenia gravis, where you elicit fatigability, and then the opposite of it will occur in Lambert myasthenic syndrome. Lastly, the muscle. So when it comes to myopathies, like the internists will receive patients with myopathies mostly, and then also the endocrinologists as well as rheumatologists will also come across patients with muscle weaknesses. So we have this acute one-off or one-time myopathies in the form of rhabdomyolysis, then we have these episodic muscle weaknesses where we have to think of periodic paralysis, hypokalemic, hyperkalemic, cytotoxic periodic paralysis, and Anderson-Tawil syndrome. So those are periodic paralysis. Then we have these metabolic myopathies where the patient will present with exertional muscle pain, sometimes cramps, and weakness. So these are episodic. And here we should not forget myasthenia gravis that also can come up as episodic weaknesses. So then the neurologist will usually come across these chronic muscle weaknesses. So here we come across muscular dystrophies and congenital myopathies. The common ones that you may come across are facial scapulohumeral muscular dystrophy and limb girdle muscular dystrophy. Now, the things here are the involvement of the face, sparing of the deltoid, and the peroneal or the lower leg involvement, and the asymmetric onset in facial scapulohumeral muscular dystrophy as opposed to limb girdle. So here are the patterns. Here you can see that three muscular dystrophies, common ones, can present with foot drop with peroneal involvement, Emery-Dreifuss, facial scapulohumeral, and Duchenne and Becker muscular dystrophies. So these are just patterns. I think if you know the facial scapulohumeral and limb girdle, that will be most of the cases that you come across. So now we have finished the first journey. We are now going to embark on the second journey, the reverse journey of patient presentations. So first question we have to ask in our history and examination, is this upper motor nerve? So the things that we usually miss are, now if the patient has a significant degree of wasting, a significant reduction of power, and areflexia, we have to think of lower motor nerve diseases. Then these are some classic patterns that should be there on the back of your mind when you're thinking of neurological patterns. So next, these are the key questions you have to ask in order to arrive at a pattern recognition process. What components are involved? Motor, sensory. When it comes to sensory, the large fiber sensory, proprioception, is it affected or not? And whether the patient has symptoms of autonomic impairment. Then the most important 4 questions is with regards to the distribution. So more or less what we see here is distal versus proximal, symmetric versus asymmetric. So the first question, now there are 4 questions that we will ask here. The first is it only one limb that is involved? So if it is just one limb, we are thinking of root or plexus diseases. Then if it is not just one limb, then the next question we ask is the upper limb involved? Is the proximal part of the upper limb involved? And then is there sensory loss together with this weakness? If there is no sensory loss, we are thinking of more like myopathy and neuromuscular junction patterns. If there is sensory loss, we are thinking of demyelinating diseases. So then the next question we ask is there distal weakness? So if there is no proximal weakness, then next we ask, is there distal weakness? If there is distal weakness with distal sensory impairment, then we are thinking this is length-dependent neuropathies. The next question we ask is everything patchy? Patchy sensory motor on one side and patchy motor alone on the other side. So this is our second question. So the third question we ask is there cranial nerve involvement? Then is there upper motor nerve involvement? Then of course we ask from the patient, how long did it take for the disease to progress? Lastly, we take a little bit of background history. So we ask whether there is any infectious etiology, inflammatory, or whether there is evidence of an underlying malignancy, and whether there is exposure to toxins or drugs. So this is a concise history and examination, and the questions that we have to ask from ourselves in the process. The pattern 1 I have already described, the patient does not have proximal upper limb involvement. It is distal, motor, and sensory. So we are thinking of length-dependent pathologies here, most of them are axonal pathologies, but we also have to think of rare demyelinating diseases like distal acquired demyelinating symmetric neuropathy or DADS. The next pattern is the demyelinating pattern. So there is upper limb involvement, classic upper limb involvement, and proximal weakness is also there, and there are sensory symptoms and sometimes signs. So if the patient has mostly sensory symptoms but less signs, and the onset is acute, if there is autonomic system involvement, and if there is cranial nerve involvement, we are thinking mostly in the line of AIDP. If it is chronic and there is no cranial nerve or autonomic involvement, we are thinking of CIDP. The third pattern is very straightforward. You have a single limb involvement, you have pain, radicular type of pain, and dermatomal distribution, so that is radicular plexopathies. The fourth pattern is the small fiber neuropathy. So here the patient is complaining of pain. Now they may complain mostly of pain in the peripheries. So pain may be like heat. They would say it is as if you have applied chili. So then it could be like frostbite sensation or different very abnormal sensations they will complain of. It can present in a length-dependent manner. It can also present in a patchy manner. And in this patchy episodes, there may be autonomic dysfunction as well. So here, the objective sensory impairment may not be there. Especially the large fiber involvement is not there. So your proprioception will be normal in small fiber neuropathies. The fifth pattern, the patchy sensory motor. So the patchy sensory motor, we are thinking of three main diseases: mononeuritis multiplex, diabetes, secondary diabetes, vasculitis, some infections, some malignancies, and then we are thinking of the demyelinating component, the Lewis-Sumner syndrome, multifocal acquired demyelinating sensory and motor neuropathy, or MADSAM, where the pathology is demyelination. And then we are thinking of compression policies, hereditary neuropathy with liability to pressure palsy. So these people are liable to pressure palsies with trivial trauma or trivial compression. So they will come up with compression neuropathies. So that is the third presentation. Next, we move on to the patchy motor involvement, where they will not have sensory involvement. So here, of course, there are actually five diseases that you have to think of. The first one is motor neuron disease. In its classic presentation, it has upper motor nerve signs as well. And then you have the lower motor nerve only motor neuron diseases, and also the lower motor nerve predominant patchy motor ones. Multifocal motor neuropathy is one. Then Hirayama disease or distal spinal muscular atrophy is one. Inclusion body myositis is one. And dystrophy of myotonia and rare distal myopathy is the other. So in these presentations, the patient will have distal motor. And in majority of them, it is patchy. So next we move on to, now that was asymmetric or patchy motor. Now we are moving on to symmetric motor. Now mind you, symmetric motor, majority of the cases are proximal. So proximal symmetric motor, we are thinking mostly of myopathies. Symmetric motor proximal. No sensory involvement. And also we have to think of neuromuscular junction disorders where we have to elicit fatigability in these patients. Then there are diseases which can have both proximal and distal involvement. Things like motor neuron disease, the lower motor nerve component, the flail arm component, and then others like AMAN and spinal muscular atrophy. If it is just distal, the classic 5 things that we discussed for distal weaknesses again comes here. Because all the patchy ones with time will develop into symmetric motor diseases. Then, of course, we have other patterns like proprioceptive loss, and that is mainly due to sensory ganglionopathies. So here we have to think, now the patient may come with unsteadiness. When I'm watching the face in the morning, I tend to fall. In the darkness, in the night, I tend to fall. So that is more towards a sensory ganglionopathy. We have to think of paraneoplastic causes and inflammatory causes here. Then there can be other mimickers as well, where patient will present with unsteadiness. Then there can be the autonomic pattern, where the patient comes with autonomic dysfunction. Now, some of these cases of autonomic dysfunction also have small fiber neuropathy, so they will have painful neuropathy. So here again, when there is autonomic dysfunction, we have to exclude other common causes of autonomic dysfunction. The last pattern is the midline pattern. So midline patterns give rise to bulbar weakness, external ocular muscle weaknesses, and facial weakness. So if it's an acute patient, we have to think of GBS unless proven otherwise. Then we also think of myasthenia gravis if it is episodic with fatigability. Then, of course, your individual cranial nerves can get affected due to many other pathologies. So the last pattern is mixed pattern. So mixed upper motor and lower motor. So patient will have both upper motor symptoms and lower motor symptoms. So here, the main differentials that we have to think of are vitamin B12 deficiency, spinocerebellar ataxia. In spinocerebellar ataxia, there will be cerebellar signs, pyramidal signs with neuropathic pattern. And there are some others which are not very common. So now this is the pathway to pattern recognition. So we initially ask, what are the components involved? Is it motor, sensory, proprioceptive, autonomic dysfunction? Then we ask the question, is it just in one limb or is it more than one limb? If it is in more than one limb, we ask from the patient, is there upper limb involvement? If there is upper limb involvement, we ask whether there is proximal involvement. If there is no proximal involvement, we ask whether there is distal lower limb involvement. If there is distal weakness, we ask, do you have sensory symptoms in the distal limbs? Then the last one is whether there is patchy involvement. So patchy involvement can be patchy sensory motor or patchy motor alone. Then there are some points, additional points. So if you have, now sometimes the patient with proprioceptive loss may come to you saying that I cannot walk. Rather than actual weakness, it may be due to secondary proprioceptive loss. Then if the patient comes with significant weakness with reflexes being intact, we have to think of myopathies and upper motor nerve disorders and neuromuscular junction disorders. Then, if the hyporeflexia or the reduction in reflexes is disproportionate to the weakness and wasting, we have to think of demyelinating disorders. Then, in hereditary neuropathies, because they are very, very long-standing diseases, the patients will not complain of sensory signs. But when you examine, you will find that there are sensory signs. The other important point is, now in motor neuron disease, strangely enough, the extraocular muscles are not involved, and there is no cerebral autonomic involvement. In CIDP versus AIDP, there is lack of cranial nerve involvement and autonomic dysfunction. So now we have actually went through a quite quick journey in the interest of time. So now I think we have only 5 minutes left. So let's go through a few patterns on examination. So here you have a patient with urea. I'm sorry, with polymini myoclonus. And as you can see from the right-hand side picture, there is oblique atrophy. So in Hirayama disease, what happens is there is injury to the anterior horn cells. Now, classically, it is asymmetric and usually involves C7, 8, and T1. So it spares the brachyradialis because brachyradialis is supplied by C5 and C6. So this classic pattern of oblique atrophy comes in Hirayama disease. And then there is another pattern called reverse split hand, where you have the hypothenar eminence being wasted more than the thenar eminence. The other pattern is Gilead-Sumner hand. This occurs in thoracic outlet obstruction. So thoracic outlet syndrome, where you get sensory symptoms predominantly in the ulnar aspect of the hand, whereas motor symptoms and wasting on the median aspect of the hand. So this is similar to motor neuron disease split hand. So yeah, this is one of the signs. Okay, I think this is stuck. So the next presentation is finger drop presentation. So here, now if a patient comes with finger drop, what are you going to think of? You will immediately think of whether this is posterior interosseous nerve involvement, but it can also be due to cervical radiculopathy root involvement. It can be a manifestation of GBS, a manifestation of AMAN. It can also be a cortical hand. Then we also have to think of other rare distal muscular diseases. And also, classically, if the patient comes with differential finger drop, we have to think of multifocal motor neuropathy. And there have been rare cases of myasthenia presenting with finger drop as well. This is stuck. So, I'm sorry, I cannot see the screen from here, so I'll just use this. So, what happens here is now these are some classic manifestations of facial scapulohumeral muscular dystrophy. So here you have this classic winging of the scapula, which I am trying to demonstrate. Uh, And then you have this classic polyhill sign where the deltoids are spared. So the muscles, the proximal muscles of the upper limbs look like multiple hills. We call it the polyhill sign. Then you can see the transverse pectineal line, pectoral line, where you have pectoral muscle wasting and manifesting with a transverse line across the chest. And thirdly, we are demonstrating the beaver sign, where you have sparing of the upper abdominal muscles and involvement of the lower abdominal muscles more. Uh, I'm really sorry, but I could not play that. So moving on to inclusion body myositis. Now this is one of the distal myopathies. So here the classic involvement includes the involvement of finger flexors, the quadriceps, and the tibialis anterior, where the ankle dorsiflexion will be weak. So these three classic weaknesses will be there in inclusion body myositis. So this is the case of dystrophy myotonia. Now where we are eliciting myotonia. First we are eliciting grip myotonia. As you can see, there is failure of relaxation. Next, next we are eliciting percussion myotonia. And lastly, we have the classic diver worm sign on EMG. So dystrophy myotonia, there are classically two types, type 1 and type 2. Type 1 is the one that manifests these myotonias and distal weakness more compared to type 2, where the weakness will be more proximal in type 2. So the next pattern is hereditary neuropathies, where now these are long-standing neuropathies. So here there will be evidence, a lot of deformities. So the clawing of the toes, then pes cavus, then the various deformities at the ankle joint, and then the classic reverse champagne appearance. So these will be there in hereditary neuropathies. So we have gone through the presentation. Now we have gone through a journey of anatomical locations of the lower motor nerve, where we have discussed about the anterior horn cell diseases, root and plexus diseases, what is different there, what is important there. And also we have classified peripheral nerve diseases to help with pattern recognition. And also we have then given you some patterns which will make it easier for you to identify these disorders, and an easy pathway to take where whether the involvement of one limb is there. If not, we move on to the proximal involvement, then we move on to the distal involvement, then we move on to the patchy involvement. So this is like a very short, simple shortcut for you to understand the patterns. And also we have shown you, I have shown you a few patterns in Hirayama disease, Gilead-Sumner hand, and the split hand and the reverse split hand. So split hand you see in motor neuron disease and Gilead-Sumner, and the reverse split you will see in Hirayama along with polyminima clonus and oblique atrophy. And man in barrel, I think I may have missed that because I was going through fast. So man in barrel, now what happens in this classic man in barrel is you have isolated upper limb weakness. So the patient cannot abduct the arms. So it is as if the man is stuck in a barrel. 25% of these cases are females actually. So it's not man, it's person in barrel. So here, now this is actually a classic description of motor neuron disease, flail arm syndrome. But the commonest cause for man in barrel is a stroke. Watershed infarct is the commonest cause for man in barrel. So there are a lot of causes like radicular plexopathies, then motor neuron disease, some cases of HIV-associated anterior horn cell involvement with man in barrel. And of course, we met with a rare case of a CSF leak giving rise to root compression and man in barrel. So it's just that the roots are affected here. So it's not just in motor neuron disease, but it can occur in lots of other cases. So then we went through finger drop. We know that it could occur in cortical hand. Then we went through the classic findings in facial scapulohumeral dystrophy, how to differentiate it from others. And then we have go through inclusion body myositis, and we presented you interesting case of myotonia and what to expect in hereditary neuropathies. So I know it was a crowded presentation, and thank you for patiently listening. So thank you.
Thank you for that very excellent presentation. It is very, very useful for the trainees that we invite the audience for questions.
I do not have a number, but I think we have seen yes, we do see like in our practice around, I think, suspected inclusion body myositis. Yes, I might have seen around 4 to 5 cases. So I think we do see it commonly. But
So I think we are like blessed with sort of other tools like the EMG and Registrar and so on. What's your impression on what would have been like the days when the clinician neurologists did not have what percentage of sort of things were mismanaged and so on? What's your opinion?
Well, it's difficult to say because I think most of these diseases, the prevalence increased with the advancement of all these diagnostic advancements of diagnostics. So, but however, in neurology, the clinicals play a major role. So I think some of these cases were diagnosed even in the absence of those so I don't think it's I know it plays a crucial role in confirming the diagnosis, but again, I don't think it's in neurology is very clinical. So I think they would have made most of the diagnosis. I mean, yeah. So
I just ask a quick tricky questions. Any other questions from the audience?
Yeah. And then you do kind of make it into an algorithm sort of thing, so that the training can easily go to into the somebody to say somebody with the drop or I think that's
yes, it's very difficult. But I tried first. Now this first to exclude the upper motor nerve, and then that part I was trying to develop one, but then I don't know how I mean it may miss some other things, but again I was trying to do that here, so I think that will be useful. Yes.